Welcome to the American Cancer Society Cancer Action Network's 9th Annual Policy Forum here in New York. My name is Marcia Earle, and I am State Lead Ambassador for ACS CAN in New York. That affords me the honor of serving as the lead volunteer on our state and local policy campaigns, and the privilege of standing in front of each of you this morning. We began hosting the Policy Forum shortly after I joined ACS CAN as a volunteer, a role I was motivated to take on following my experience with ovarian cancer. As a survivor and an advocate, I find that the Policy Forum serves as a perfect venue to take stock of where we have come and where we are going in the fight against cancer. Here, we discuss new avenues and tools that aid in preventing, detecting, treating, and defeating cancer. Last year, we discussed the innovation happening in early detection and screening, and soon we'll hear from public health, medical, and industry leaders on a burgeoning approach to care through patient navigation. We are here today to explore the ongoing challenges in efforts to screen patients for cancer and discuss how patient navigation is the future of patient care. Soon you'll hear from experts on how we can, through expanding awareness and access to patient navigation, prioritize patient needs, reduce disparities, and promote health equity. ACS CAN is eager to take on these issues, celebrate their potential, and secure community access. Today we welcome leaders from the life sciences, healthcare, government, academia, and business to discuss how we can both build awareness of patient navigation and improve access to this critical community resource. Before I introduce our keynote speaker, I have a few people and groups I'd like to thank. Starting off with the over 1 million ACS CAN volunteers nationwide, many of whom are here today who drive ACS CAN's work. These are my fellow survivors, advocates, and friends. They are the reason I advocate year after year and remain on my mind through every trip to Albany, Washington, D.C., and back. The work that we as volunteers do would not be possible without the support and generosity of today's Policy Forum sponsors. Support of these individuals and institutions empowers ACS CAN to be the most effective cancer fighting organization in the nation. So I begin by thanking our associate sponsors, Janssen Oncology and Pharma. Our bronze sponsors include ASI, Merck, Northwell Health, and Reed McNally and Savage. Our silver sponsors include Amgen, Bristol Myers Squibb, Genentech, Grail, Novartis, Sanofi, and Syndax. Our gold sponsors include AstraZeneca and Pfizer. And finally, a special thanks to my fellow volunteer and ACS CAN National Board Vice Chair, John Nana, for his support. Please join me in a heartfelt thanks to our sponsors. Okay, here's the audience participation part. You can show our volunteers, panelists, and partners some additional love and express your support for patient navigation through a post on social media today. We encourage you to post and tweet using our hashtag FightCancerNY and the handle @ACSCan_New York. If you're not already following us, @ACSCan_NY, because there we are. And before we move on, I would like to introduce ACS CAN's Managing Director of Advocacy, Bill Sherman, to say a few words.
Good morning. Today I'm here with a heavy heart. Molly Williams was the Senior Director of Alliance Development at Pfizer. She was a massive supporter of this event since its inception and was always here with us. Unfortunately, on Monday, Molly lost her battle to cancer. When I joined the American Cancer Society Cancer Action Network 10 years ago, Molly was the first person outside of our organization to call me and welcome me to this work. You see, Molly and I had worked together for many, many years in the State Assembly since the early 2000s. Her kindness and friendship was something I knew very well. However, that wasn't the first thing you noticed about Molly. When Molly called a member of my team, they usually felt nervousness. They even had some fear. You see, Molly was also a tenacious and driven advocate. She was focused on making sure patients had access to the best treatment options possible. She worked tirelessly to remove barriers to treatment, and with that came a drive that was nearly unmatched in our work. One of the assembly members Molly and I worked for, George Winter, he was our floor leader at the time. He used to say to us, "Give me a set of brains on this bill." Well, for me and my team at ACS CAN in the Northeast, Molly was often our set of brains. Many of these access issues are really complicated, but Molly and her team were always there to explain how the issue impacted patients. She was our set of brains. Molly was a titan of public policy. And speaking of titans, we also lost two of our fiercest cancer fighters this year. In your program at the end, you'll see pictures of Karen Birnbach and Joan Farmer. They were two of our volunteer leaders and were a constant presence with us in Albany, DC, and in the district offices back home. Our hearts go out to Karen and Joan's families, and to Molly's husband, Jeff, and their two beautiful children, and to her Pfizer family, several of whom are here today with us. On Monday, we lost a dear friend and a fierce advocate for patients. These losses remind us of why our work is so critical and why we can't stop that work. Please join me in a moment of silence in Karen, Joan's, and Molly's honor. Thank you.
Thank you, Bill. Molly's and Karen's and Joan's memories remind us why we need to keep doing this. Keep up the fight. Okay, I'm going to turn the page. We can do this. It is now my pleasure to introduce our keynote speaker, Bruce Ratner. In his long career, Bruce Ratner served as New York City's Commissioner of Consumer Affairs, an NYU law professor, and the founder, chairman, and CEO of Forest City Ratner Companies, a major property developer. He led the economic revival of downtown Brooklyn, built the Barclays Center Arena, brought the Nets NBA basketball franchise to Brooklyn, and helped restore Times Square, including the New York Times headquarters. For more than 2 decades, Mr. Ratner has applied his deep interest and background in the sciences by serving on the boards of Weill Cornell Medicine, Memorial Sloan Kettering Cancer Center, and the Cold Spring Harbor Laboratory. He founded the Michael D. Ratner Center for Early Detection of Cancer in memory of his brother, to advance the fight against cancer through life-saving screenings and research into new diagnostic tests. Through the center, Mr. Ratner has promoted early detection testing for lung cancer, particularly in low-income and underserved populations. He has written on this subject in his book, Early Detection: Catching Cancer When It's Curable, complimentary copies of which can be picked up at the information table in the lobby. I encourage everyone to grab a copy on your way out and give this great book a read. So now please join me in giving Bruce Ratner a warm welcome.
thank you all. I'm going to sit because my back needs some work, so it's much easier to do this, so thank you. Let me get in the chair. So first of all, I want to thank everybody for inviting me here. You are a very special group. The American Cancer Society is extraordinary. And I'm so proud to be able to be here, honored. I see my MSK folks here also, but all of you, all the work you do is so incredibly important. You know, I like to think one thing that happened this year was ACS too, which is incredible. You came out with a new protocol on lung cancer, which was any person who has had 20 pack years smoking or more, whether it was 10 years ago, 15 years ago, 25 years ago, or 40 years ago, should get screened. I cannot tell you how important that is. The old protocol covered maybe half of the people that should get screened. What you've done in that protocol was very brave, because for years, as I've worked on this, everyone has been afraid to do that. You were not afraid. And that is a huge, huge change. And we just now have to get the government to go along with it. So that's not quite as easy. What the work you do is really good, and I'm very proud to be here and honored. So I'd like to talk today about a few different things. The first thing is that we have to work together. Early detection of cancer is the answer to cure. It's the only real answer to cure. Because if you catch cancer late, in an advanced stage, stage 4, say, or metastatic, you have about a 10% chance on average of survival. If you catch it early, you have a 90% chance. In the case of breast cancer, 99%. Colon cancer, 99% survival. Those numbers are dramatic, and that's why we have to catch cancer early. And lung cancer, which we've got, as I mentioned, lung cancer is responsible for almost a quarter of all mortality from cancer. And so, unfortunately, as many of you may know, only about 5% of the people who are heavy smokers or were heavy smokers actually get screened. So one of the major initiatives that has to be done, we need to improve that, because that alone would save more lives than something which I believe in strongly, MCEDs, and they're great, and we'll talk more about that. However, just think about that one thing, lung cancer, which we've spent a lot of your work on, both in terms of cessation and in terms of your protocols. So I'd like to just start by saying that is really important what you've done with this story. So let's talk about some other things about early detection. This talk will be around 15 to 20 minutes, let's say 20 minutes. During that period of time, in this country, 20 people will die of cancer. One every minute. 20 people, that's all we're seeing. 1 out of 2 of us men will get cancer. 1 out of 3 women will get cancer. So we all face something which is scary, which affects our whole family, and we've got to do even more. As much as you do, we have to do more. You know, Marsha mentioned, that I'm interested in this is my brother. So I had a brother. He died about 8 years ago, and Michael was a famous human rights lawyer. He was a year and a half older than I was. My parents died when we were younger, and we were inseparable. I say inseparable. There's old, I call them videos now, probably Super 8 film, where if you show us tricycles, Michael turns this way, I turn this way. And so that's who he was. And that's what really got me interested. I was at Sloan Kettering. They saved my brother for 8 valuable months that no one else could have done. He had a very rare type of metastatic cancer, had 2 weeks to live, and Sloan Kettering kept him alive for 8 months, and that was a wonderfully important 8 months. However, like all of you, because everyone here I know has been touched by cancer in one way or another, whether it's a parent, whether it's yourself, whether it's a sibling, whether God forbid a child, whether it be a grandparent, whether it be a close friend, people you mentioned, we've all been touched with it in some kind of way. And we all know what it feels like, but just think about this. If you could have kept that person that you love so much for another year, for another 2 years, can you imagine how wonderful that would have been, let alone a life? So you catch cancer early, you're going to have a full life with that person. How many of you think about it? I know what I do. I pick up the phone every day, and I talk to my parents, one of them died of cancer, and I talk to my brother every single day. I wish that we were actually, tears are coming to me. I wish I could actually do that in person. And that's what we all hope. So let's talk about things we have to do. So what I would recommend that we try and put together is a coalition, which you've already done in so many different countries. Put together a coalition where we give ourselves a certain number of years, say 5 years. And we set kind of priorities which you have already begun to set. And patient navigation is one of the major ones. And over that 5-year period, we've got to work to accomplish those things. And I'm going to mention a number of things. So let's actually start with patient navigation. So what happened was, as I was writing the book, I realized a new kind of, then I began to see the disparity issue. So let's give some data disparities. Okay, in the case of African American women and Caucasian women, the incidence of breast cancer is the same, right? It's slightly less for African American. Yet the mortality rate is 40% for African American women. We can't let that happen. We cannot let that happen. Another example, there's a Ward 7 and Ward 8 in Washington, D.C. They're some of the poorest wards, precincts, areas in the country. 50% of people who get diagnosed with cancer, they're Medicaid, within those 2 wards, don't get treatment for a number of reasons. Or they start treatment and they have to quit for all the social concerns they're aware of, whether it be food desert issues, whether it be taking care of their children. I know when I would go with my brother to Sloan Kettering for infusions, I would take 3 hours off of work, we sit and we talk, I took the day off. That a lot of people can't do. We all know that. Their jobs won't allow them, they're taking care of their children won't allow them. We know the issues of disparity. We know how much has to be done because people who are low-income, underserved communities, we know they have burdens which we don't have. And it could be anything from food, to diet, to jobs, air, everything you can imagine. And so my wife said something very interesting. She said, Bruce, you understand that patient navigation is the one Band-Aid we have which can begin to close that gap. It's a Band-Aid, but it's a critical Band-Aid. It's like having a cut and you got to stop it from bleeding. The Band-Aid is patient navigation, if you think about it. I cannot fix the food desert part. I cannot fix work issues. I cannot fix all of the problems that the underserved have. But we can do one thing, which are already very, very common, I'll say, which is patient navigation. And so in my book, I would say, probably woven in there, patient navigation is probably as important as anything. And as many of you may or may not know some of this, they say, a man named Harold, a doctor, named Harold Freeman, who was at Sloan Kettering, created patient navigation. And he liked Sloan Kettering a lot, and he did a lot of stuff there. But then he decided he was going to go to Harvard Hospital. And what he did was he opened up a Saturday morning. Every Saturday morning he had a clinic for women to come in for breast cancer screening. In the beginning, what he found is that something like 40% of the women who came in were stage 3, stage 4, and so on. But as he did it over the years, it all switched around. Yes, he had as many people coming in who got breast cancer, but it reversed. 40% were in stage 1 and 2. And that's what patient navigation was able to do. Come in and change things. Now, why was patient navigation important? How do you get those people to come in? He said, you've got to have people that make sure everyone comes in for appointments, that they get screened, that they understand what the screening is about, and that is one of the things that patient navigation does, as you already know what we learned today. And so he created this notion of patient navigation, and he really changed the world of cancer. And now it's our job to continue that movement of patient navigation. As you all know, there have been some changes over the last year, somewhat positive changes, and I know you're behind a lot of it. But we've got more to do. As you know, the amount of money available is not sufficient for what's necessary. It is true that the big hospitals, Sloan Kettering, and so on, can afford to have patient navigators without necessarily getting reimbursed. But most hospitals cannot. I work with Sloan Kettering and Jamaica Hospital in Queens, and they do have patient navigators. They're a capitation model, and so they do, but they can barely afford it. And they're one of the few hospitals that's in an underserved community that's able to have patient navigators. So we'll talk more about that today, but the only Band-Aid we have that I know of to change the disparity issue is patient navigation. Because I go to different lectures and I talk various places, and I hear about the technology technologies that are being invented and this and that. And then I say one word, implementation. Great, we've got a new technology. Now, how do we implement it? And most importantly, how do we implement it for the underserved? That's the real issue. And yesterday I was at a conference where I spoke with the other people. It was a great conference. You had a wonderful person there. However, all I heard about was new technologies and all these things and that things and so on. But the truth of it is that it really is about implementation. And in terms of underserved communities, it really is about implementation. You know, I worked in downtown Brooklyn for 35 years. I live in Brooklyn. My wife was actually the CEO of the library system. And Brooklyn is 50% Medicaid patients, 2.7 million people. And the issues of poverty in that borough or Queens or the Bronx is just extraordinary. Some of us don't realize how very low income, the number of very low income, I use the word very because it's a definition, an economic definition. Very low income people in this city is a large number, whether it be housing, whether it be healthcare, whether it be food, whether it be education, and so on. And it's also interesting to notice where are our great hospitals? They're on York Avenue and Sinai, a couple other places. And there's a history of that. That history of where our great hospitals are is the same in virtually every city. They're congregated in one area. It goes back to the 1800s that the great hospitals, the great doctors were centrally located in the wealthy areas. And so not only MSK is extraordinary. I've never actually been involved with any institution that's so extraordinary of any sort. I've been on a lot of their boards and so on. But the location of the hospitals, the location of the really good hospitals, traditionally have always been in well-to-do neighborhoods. They are not in Bushwick. They are not in Morrising. They are not in Harlem. And so on. And so that's historically the case. And we have to fix that. We have to fix it in all kinds of different ways. MSK is working with Jamaica Hospital, which is a capitation hospital primarily. We're doing a lung cancer screening program that we just started there because we want to work out all the problems in lung cancer screening and use that as a model for underserved neighborhoods. And that's really what I'm doing, really have written the book. Real emphasis is on trying to change things, particularly we start with lung cancer, but in all kinds of areas. Because if you look at almost every one of the screening tests, they're great to have, but there's problems with every one of them. A good example is mammography. Mammography misses 25% of the cancers. And that's a very large number, obviously. And misses them for 4 or 5 different reasons. Issues like interval cancer. Interval cancer means I get screened this year, and I don't get screened maybe for another 3 years. Cancer comes in between them. By nature, if you give cancer 3 years and it's an aggressive cancer, your likelihood of dying is 3.5 times as if you got an annual screen, with the mortality rate. So that's one of the things. So what I would think is really the best idea for all of us to do is to go through all of the different issues that you know about and I could talk forever about, and let's get them fixed over a 5-year period. Let's have some goals, and let's have some metrics. And it's critical. We have to have metrics. We have to not just go to the community and say, oh good, I went to the community, I talked about lung cancer or breast cancer, or prostate cancer or cervical cancer, colon cancer. Let's get metrics and see if we're really doing the job. And let's get things changed. So talk for another moment about breast cancer. There's so many issues in the case of mammography. We have issues. It's $40 more if you want your mammogram read with AI cash. Then, if you have dense breasts, you really have to have an ultrasound, but probably an MRI. That is hard to get covered. It's hard to get the insurance companies to cover, and that's really necessary. 50% of women have dense breasts. 15% have extremely dense breasts, and you have to have an MRI. And yet, it's covered, but to get the insurance companies to actually cover it is almost impossible. There may have been an article that you read recently. This is an incredible fact. There are a couple companies that have done algorithms where an insurance company can say, you know what, I'd like to get 15% of all of the dollars that are spent for reimbursement eliminated. Therefore, I want you to make sure turned down 15% of all the dollars that we're supposed to reimburse. They've died. If you want 20% in your hospital, that can get done. That we have, there's one state, and I don't remember the last name, that forces insurance companies to disclose what percentage they turn down. We need to get that passed federally and in every state. In New York, this year, let's get a law set which says that every insurance company has to disclose its rate of turndowns. And you're going to be shocked. Let them compete. And let them compete so that the one that has the least turndowns is the one that people commercially get. Make sure Medicaid discloses it, and then Medicaid discloses it. You will be shocked. And the incredible thing is, again, you can dial it up or you can dial it down. There are algorithms that the one or two companies that do that have, that they can do it extremely well. Lung cancer screening, I don't need to keep going back about that, but that's a very good example. Do you know that one of the problems lung cancer screening is the pre-approval? So what does that mean? You have to show that you smoke. The turndown rate for people who have smoked before and who say they smoked before, and the prescription that was given, which is needed, which is not needed, breast cancer, another screening, you have to sign something which says I smoke. And the problem is that still insurance companies turn down. We work with a large radiology center in Bronx, and they have a room about the size of this stage, and all that's done there is talk to insurance companies to try and get things approved. And one of the biggest ones is the lung cancer screening, where the insurance companies do not believe the person smoking over the last 15 years. So we've got to change that. We've got to have to disclose that. So, and there's so many other things through lottery that have to be fixed. And so that would be one of our major issues on our agenda. And then I know Marcia mentioned ovarian cancer is something that I find extremely important. Why? Because you know it's a silent killer. It's a very dangerous cancer in the sense of predicting what's going to happen. You know, prostate cancer is very different. Prostate cancer, you can actually watch and you can see if your PSA goes up. You can monitor that. You cannot monitor ovarian cancer in any decent way. The various 2 or 3 tests aren't going to be accurate. And that disease can change from indolent to not indolent in a period of 6 months. It's doubling time, which is a very, very important issue. Can go from 100 days to 200 days down to 20 days overnight. And so we've got to work on that, and we've got to really do something about ovarian cancer because it's a very aggressive cancer sometimes. It's hard to disclose. It hits young people, and we also don't know whether a cyst is cancerous or not. We don't know if it can turn cancerous. So, and obviously pancreatic cancer, many, many people talk about that, obviously has to be worked on. But there are issues that we can work on that don't have to change the world, or that they will change the world, but they don't have to be the technology. And that's really the emphasis. We've got plenty of stuff now that we've got to do. And let's talk for a couple minutes about MCEDs. So yesterday I was actually with Josh Hoffman. Josh Hoffman is the CEO of Rail. And without going into great detail, I'm a strong believer, as I know you are, in MCEDs, multi-cancer early detection tests. People will say too many false positives for all kinds of different reasons. The words I hear all the time, and I say something with it when a doctor doesn't think there should be screening, is too many false positives. I go to sleep thinking about those words, too many false positives. It's easy to say, but a lot of times it's just plain false. There are not too many false positives. It is a reason that you'll find that doctors will say you can't get a test. You can follow most cancers by imaging. So if you do have a positive, you can figure out whether it's a false positive. So I want to emphasize that multi-cancer early detection really are the future, the absolute future of really cancer detection. And we've got emphasis and we've got to get it done. It's going to require federal passage of reimbursement, and that will do it. So I've got to close. I saw a 5-minute sign go up, and I could talk forever, and then you won't be able to listen to really good talks. So let me just close by saying thank you very much. I think, again, I can say it again, we should put together a plan together with a lot of other organizations that you know, that I know, that puts together a 5-year plan or a 3-year plan. We'll decide on the things that we must accomplish over the next 3 to 5 years. And I will let's get that done, and that would be a major change. A period of time requires certain things to get done, and monitor them and measure them. So with that, I want to thank you. I always end this way. Get screened, but let's talk about lung cancer one more time, because it is the one that you can do something about. Make sure, now that you have your new rule, that anybody you know who smoke or 20 packers at any time in their life gets the screen. That's the one thing you can do. You know a lot of people who used to smoke, and they just, doctors kind of throw, oh, this was over 60 years ago or something. But I ask you to let's do that one thing at least. And let's also make sure that mammograms are done regularly, done, I think, every year, not every 2 years, because of uterine cancer issues. Let's do those two things, at least. Each one of us can do that. So if each one of us does that, it will change people's lives. So thank you very much.
What a call to action, huh? Love it. Thank you very much, Bruce, and thank you for the message and for your incredible commitment in the fight. Allies like you are critical. Okay, now it is time to shift gears and explore one of the critical issues raised by our keynote speaker, patient navigation. I would like to introduce the moderator for our panel. She is the Associate Cancer Center Director for Cancer Care Equity at the Yale Cancer Center. Dr. Tracy Battaglia is a primary care clinician investigator, internationally recognized for her collaborative, innovative approaches to addressing health disparities among historically marginalized women. Her research focuses on engaging in communities to increase access to care for at-risk women, including groundbreaking work on the role of oncology patient navigators. As founding chair of the National Navigation Roundtable, she partners across sectors for a sustainable navigation workforce. Please welcome Dr. Tracy Battaglia.
Good morning, everyone. So you make it up the stairs, that's the first thing that you have to do, and you don't fall, that's a success. So let me start by saying how super excited I am to be here, and how privileged I am to meet Mr. Ratner and to sort of hear his inspiring remarks. I think, he so eloquently stated that we all are touched by cancer in some way. And so for those few people in the room who do know me, you know how passionate I am about patient navigation. So let me share with you why. I've been doing research. I'm a primary care physician scientist, trained in preventive medicine and women's health. And I did all my training and spent 30 years on faculty at Boston University and Boston Medical Center, which is the largest safety net center in New England, small in comparison to the larger academic institutions around us in Boston. And so I learned very early in my career that my cancer experience as a stage 4 cancer survivor at the age of 20 was starkly different from the patients that I was serving. And it was that work, that experience that inspired me, as your own experiences are inspiring me to be here today, to spend the next 20 plus years doing scientific investigation of patient navigation, demonstrating and supporting many others who've built this foundational evidence of navigation, that it can reduce inequities. So you can imagine my dismay in 2018 when I was diagnosed with my second cancer, that experience was starkly different from the same patient in my health system who was diagnosed with a more advanced stage of cancer at the same hospital at the same time. So I am here to say we can do better, and we should do better. We heard from Mr. Ratner, who I feel like should have an MD behind his name, because you have a real serious sort of command of the science and the literature and everything. And so thank you for setting the stage for this conversation. Patient navigation is one of the only health systems intervention that has been proven over and over again to reduce inequities in cancer care delivery. If we were a little pill, we would be on everybody's formulary. But we are not, and that's why we're here today. So I want to say the science says navigation can improve outcomes from screening to diagnosis and treatment. As advances in screening and diagnosis and treatment occur, disparities widen because there's not equal access. Navigation can level the playing field. I also want to say that our patients are asking for navigation. The American Cancer Society survey, recent survivor survey demonstrated from nationally, patients, 91% of patients surveyed said they think navigation is important in their care, but only half of them had access to one. We can do better. So I commend the American Cancer Society and ACS Ken for making patient navigation a priority for discussion this morning. I am grateful for the active membership of ACS and ACS Ken in the National Navigation Roundtable, which we're going to hear a lot about on our panel today. And I'm grateful to be invited to learn from our esteemed panel. And so we have about an hour for conversation. So I'm going to call our panelists up and get us started. So let me start with putting on my glasses and introducing Jennifer Mandara. Jennifer and I haven't met. She just walked in, so welcome, Jennifer. Jennifer is representing the nurse profession. She's a nurse manager at Northwell Health Cancer Institute. She brings 17 years of nursing experience from her navigation team as a manager. She has a diverse background that spans emergency medicine, critical care, ICU, medical surgery, cardiac imaging. So this experience provides a solid foundation for her current role in supporting lung nodule and lung cancer teams. Jen's leadership and clinical skills contribute significantly to navigation and care coordination within these specialty areas, so we're deeply grateful that you're here. Okay, our second panelist is Dr. Vikas Mehta. He is here representing Montefiore Einstein Comprehensive Cancer Center. He is vice chair and associate professor in the Department of Head and Neck Surgery. So he's a surgical oncologist by training. And he is interested in researching the clinical outcomes in head and neck cancer patients, and particularly looking at health disparities, and has his own experience with navigation in his health system. So thank you for being here. Our third panelist is Dr. Sawit Teki. She's a radiation oncologist by training, representing New York City Health and Hospitals. She's nationally recognized for her clinical research experience in head and neck cancer. She's Systems Chief of Radiation Oncology at New York City Health and Hospitals and Director of Head and Neck Radiation Oncology at Kings County Hospital. She's also a Clinical Associate Professor at NYU School of Medicine. So thank you, Dr. Teki, for being here. And last but not least, my good friend and colleague, Christina Thompson, trained as a social worker, is here representing the National Navigation Roundtable and the American Cancer Society. Christina serves currently as the director of the American Cancer Society National Navigation Roundtable, which we're going to hear a lot about. It really is sort of the coalition that has been leading this work nationally. In that capacity, she offers strategic guidance to establish a sustainable model for oncology patient navigation. She's deeply dedicated to supporting patients and caregivers and advocating for expanded equity in cancer prevention and treatment. So please welcome Christina and the rest of our panel. I'm going to join them on the chair. And hopefully they're going to switch my mic over. All right. Good morning, everyone. All right, so we can stay up here all day. I'm going to try to keep us focused. We're going to talk about, ask our panelists to talk with us about their personal experience with navigation. We're going to talk about the good, the bad, and the ugly. We're going to talk about what's working, what's not working, and what has to happen in the future to get us to where we need to be for equitable cancer care delivery. So I'm going to start out with the first question, which is I'm going to ask each of the panelists to just share 2 or 3 minutes from their own experience, their own perspective. We have very different perspectives here from clinicians and practitioners, different populations, different health systems. What is your personal experience with oncology, patient navigation, and from your unique perspective, why do you believe navigation is important? So I'm going to start to my right first. So Jennifer, I'm going to ask you to tell us a little bit about your experience with patient navigation. Welcome.
Thank you. Thank you. Good morning, everybody. Nice to meet you all. Again, my name is Jennifer. I am the patient care manager in Northwell Health for the Cancer Center Institute. We run a navigation program for all types of cancers throughout Long Island, Manhattan, and as far as Peconic Bay and as north as Northwestchester. We manage patients with all disease types, every kind of discipline of cancer. Our navigation team is 2 years old. We have nurses that are designated in every disease process from breast to head and neck, cutaneous, lung. My focus is lung cancer. I also run the lung nodule board. We see patients many different ways in our institution, range from incidental finding to direct referrals from all of our Northwell hospitals. Many of our patients come in just for scans within our system because of our vast area that we do cover. So that's a wonderful thing for our patients because they can more or less get the treatment that they need anywhere because we are so broad. And we also follow patients within our tumor boards for lung cancer and lung nodule program. We can navigate some of our teams. Our breast team is our largest team at this point. Their load is very large, unfortunately, which is very high incidence of breast cancer throughout Long Island. And there's some, and it goes on from there. We have patient coordinators that work together with our nurses. They help coordinate all of the care when it comes to our timely scheduling of our appointments and our referrals, just making sure that records are received and our patients are ready to meet the physician that they need to in a timely manner.
I have a million questions, but I'm going to hold them so I can give each of our panelists allow them to introduce yourselves. Surgical oncology, tell us your experience with navigation and why you think it's important.
Sure, yeah. So first, thank you so much for the opportunity to be here and to talk about this important topic. I sort of got into the idea of surgical or navigation for oncology patients from some research that I did. So I also, once I was a faculty member, got a master's in public health. And with that, I realized, and I remember reading this somewhere, being a physician is sort of like being a gardener for a plant. You can give that plant water, you can give it sunlight, but if the soil is poisoned, there's not much that you can do. And so part of that is you have to address some of the soil, and I know that Mr. Ratner mentioned some of that and touched upon that. But when I got to Montefiore, which is where I work in the Bronx, the Bronx is sadly, out of the 62 counties in New York, number 62. And, we even talk about, we now have a campaign, which is, we don't want hashtag not 62. And, and one of the major things that we need to do that is to fix that soil, and we have to be able to address it. And so, I treat head and neck cancer, as does Dr. Techie, and there's a reason that both of us are here, because head and neck cancer is a disease often of the disparate vulnerable populations associated with alcohol use, with tobacco smoking, and it's a very difficult disease to treat that affects people not just in terms of their lifespan, but also very much in terms of their functional and quality of life. And so treating that disease very early makes a huge difference for both of those things. And so when you see patients come with late-stage disease, one of the things that impacts that is, and their outcomes is the time from once they're diagnosed to once they're treated. And so we did some research looking at that, and we found that if patients just got treated in time, within a month and a half of being diagnosed, which sounds like an incredibly long time, if you think about it personally, you've been diagnosed with a cancer here, on your tongue or in your neck, and sitting there for a month and a half as you're waiting to start your treatment, even just doing that doubles the chance that that person gets cured of their disease. And so it's a very, as you said, if that was a pill, it would certainly be on everyone's formulary. And so once I saw those numbers and we did that research, we felt that we were sort of compelled to bring this to our patients, especially because they need it the most. They need to, when you talk about patient stories, people being able to just even afford a taxi ride from one end of the Bronx to the other is a challenge. And so, and it's difficult for them to understand the disease, for them to understand what's being told to them, what they're about to go through. And having a peer navigator or someone who's able to help coordinate that, speak to them is hugely important. That's how we got involved in it. And we've since expanded our program for screenings. We also do some things with community health workers addressing social determinants of health. So again, we could keep talking about this, but I want to be respectful of the time. Thank you.
Thank you. I just want to sort of say thank you for shining a light on such an important population and doing this work. I think everyone in this audience would agree, waiting 3 months, 30 days, 60 days to get into care, we wouldn't tolerate it. And no patients should. And so congratulations on great work. Dr. Techie, so we have a radiation oncologist in the room who represents a little bit of a different population, so we'd love to hear about your experience.
Thank you. Can everyone hear me? Yeah? Great. So nice to be here, and thank you to the American Cancer Society for the invitation. So I'm representing New York City Health and Hospitals. We are the city's public hospital system. We have 11 hospitals, a number of clinics and community health sites. We treat or see over 1 million New Yorkers a year. We treat over 5,000 cancer cases in our facilities each year, and we diagnose many more. We have 5 cancer centers that are Commission on Cancer accredited. We have 4 breast centers that are accredited. And I say all that to really show that our mission is to take good care of people, even if they can't afford the care. So we've invested a lot in these services, even if we don't make money from it. But we can do more. We can always do more. It would be so wonderful if we can get funding through legislation or through other avenues to continue these programs and services. I do also want to point out a few innovative things we do around navigation and screening. So we have a lung cancer screening program that was established 2 years ago. Our program navigators are actually here today. So we have 11 nurse practitioner navigators who run that program, and that was something that we decided was important. We invested in it. We put a business plan together, and that's now moving really smoothly. And thank you to the team for overseeing that and taking care of our patients who really need this service. So all that to say that we have a unique patient population. We do good work, but we can continue to do better. And I just want to tell a really quick story about why navigation is important. It's a head and neck cancer story. So it's a patient with throat cancer, which is kind of what we treat. And this is a gentleman who lived in Brooklyn, lives alone, has no family. And he came in to see us. By the time he'd seen me, I counted how many appointments he'd had. He'd had 12 appointments. From finding out that or discovering that he had something in his throat to when he got to start his radiation treatment, which he needed. And I won't give him any more details, but all that to say that our patients do great once we get them to care. Now, the point here is that, can you imagine living alone, working day to day for your paycheck, and having to sort out 12 appointments in the span of maybe 4 to 6 weeks? How do you do that? So we have some patients who just can't do it, and they say, look, I have to go to work, I can't come to this appointment. So that's where our navigators come in. Our navigators sit with them, they figure out, what do you need? Do you need transportation? Is there some financial assistance we can put you on? Is there anything else we can do for you? Do you need food? We have food pantries in our hospitals. Like basics, right? Getting people fed so they can continue treatment. So this is why our navigators are so critical, and like Mr. Ratner said, it's a Band-Aid. I actually think it's more than a Band-Aid. I think it's the glue. It brings us all together. If they're not there, it just falls apart. For a lot of our patients, everything's really hanging by a thread, so they are the glue. So I really thank our navigators who are in the audience today. I mean, you should be up here. I'm glad to be representing you. And thank you for the work you do.
Amazing. I love the analogy of the glue. I think your example really highlights the activities of what the navigators are really doing day to day, and recognizing that the patients that need navigation, cancer is not always the worst thing in their life that they're dealing with, and so the navigators are really supporting them around all of those other issues. And so thank you for sharing that. So, Christina.
So good morning, everybody. I'm really thrilled to be here and to talk about something that I'm so passionate about. As Tracy mentioned, I'm a social worker by training, and so I feel like navigation has been part of my DNA probably since before I decided to become a social worker, probably since I was 12, and I told my mom I was going to be one when I grew up. And I think that my esteemed colleagues here have really talked with you about the role, and Mr. Ratner did as well, as the important role. And I would say I've been privileged enough to be a part of navigation at the American Cancer Society, working on a number of projects. One, screening, colonoscopy screening with both the health and hospitals in Mount Sinai and many other hospitals here in the 5 boroughs. Funding free colonoscopies a decade ago, as well as paying for navigators to help patients to be able to get to those screenings. And we saw, what you've already heard, is that navigation is an evidence-based intervention that helps to increase health equity. We're never going to decrease the disparities that exist, but we can increase health equity. And what we found from that project is that patients got screened, they were on time, there weren't missed appointments, their prep was completed, and when someone was diagnosed with a suspicious finding, and ultimately it was deemed to be a malignancy, it was at an earlier stage. And it crossed over regardless of race, creed, religion. It got to people so that we were really helping to increase health equity. In the last few years, I've been really privileged also to work with the National Navigation Roundtable. And it was music to my ears when Mr. Ratner said, we need a coalition. We have a coalition. And so I hope to be able to share with you what the Roundtable is doing and how each of you can learn more about navigation. And I know I'm preaching to the choir here this morning, but how you can also get involved and really help us here in New York State.
Thank you. So we've already heard a little bit about, we've heard a lot about the science and the literature and the evidence base, but I wanted to spend a little time with all of you who are boots on the ground doing this work to really bring it to life for us and sort of provide, based on your experience, an example, a real life example of a patient who has benefited from navigation, or the success of your program that you were able to increase sort of population level statistics or whatever for your population. We heard a great example from Dr. Techie, but I want to give others an opportunity to share, from your day-to-day experience, a highlight of an example of where the impact really is obvious.
I agree with so much that was said after me, piggybacking off of that. There are patients out there that aren't patients, and as a nurse navigator, you have to get past that and realize there's a human behind that, and their frustrations and fears. And I once had a gentleman, unfortunately, that came out to me after he finally answered his phone multiple times, calling to leave messages, and he said, I'm ashamed to tell you this, but I'm unfortunately homeless. And I said, okay. And he said, I'm aware that I have lung cancer and I have lung nodules and I need help, but I'm literally living in a storage unit in wherever his location was. It took my breath away for a moment, and I leaned back and I said, okay. And I said, so what can I do for you? He says, I really want to go to my appointments. I want to go to the doctors, but I don't have the money and I don't have the transportation. And my brother once in a while offers me a ride, but he's inconsistent with that. I mean, sometimes I can sleep in his house and I can get a shower because, I want to shower before I go to my appointments. I don't want anybody to be embarrassed of me. And I said, okay. So at that moment, we're not even dealing with the cancer, we're dealing with the human and the way of what their life situation is, and how am I going to get this gentleman to his appointments, and how am I going to make it okay for him? And that's when you kind of sit back and just lean on your team, and you brainstorm about what the best areas for him are. So setting him up with transportation, making sure he can get to his brother's to get cleaned up, and then getting to the doctor's appointment. That all worked out, thank God, and I did reach back to him, and he was so grateful for my help and the follow-up thereafter. And at this point, he's in care. He's getting proper treatment. He's no longer living in a storage unit. And it's that connection. It's that relationship that you build with a stranger. And they trust you, and you can't break that trust. Because that trust is priceless. And for him to feel that way inside and feel comfortable enough to have that conversation with me and be so passionate about his medical care, it was a wonderful day. Wonderful day.
So I think all of us have our experience with patients who don't come for appointments, but we don't all have the resources of a dedicated team who is persistent and doesn't give up and is skilled at creating that relationship. So that patient felt safe to tell you his experience.
Yes.
And so thank you for sharing. It's a great example.
Thank you.
Dr. Matthew?
Yeah, again, I don't do the navigation, so it's actually, it's very heartwarming to hear a story like that, and that's definitely what our patients experience in the Bronx. And I think that what you see, we've even done some interview studies with patients, and it's interesting to hear sometimes them say that I actually needed the extra time to sort of process what was happening. At the same time, I think some of that comes from the fact that we aren't necessarily engaging them where they are. And when they've, there was a very famous lung cancer study where it was a multi-institutional study, and what they found was that at the time, in terms of treatment completion and starting treatment on time, there was a disparity in terms of race. With African American gentlemen starting at 70%, and the Caucasians, sort of in the 85% range. And when they brought in navigation, they didn't just bring in navigators; they also trained them on how to meet people where they were and to understand the communities that they were a part of. And that actually not only raised equaled the disparity, but everyone went up to 90 whatever percent. So it was sort of a rising tide raises all boats type situation. And I think that being able to meet people where they are, understand where they're coming from, is a very important part of it. And so I think Jennifer's story really highlights that.
I think you bring up a really important point, and that is, navigation is a term that's in the dictionary, right? It's a very sort of intuitive word. And, I think there's probably navigation happening, or navigators who carry that title who aren't necessarily practicing according to standards of professional practice, as in sort of this study. You really have to, I just want to sort of highlight, if folks are not familiar with the standards of professional practice that were published in 2022 by the Professional Oncology Navigator Task Force, I would encourage you to become familiar with them and promote them, because they're the Bible that actually has sort of supported the CMS sort of fee schedule and payment. And so it's research like that sort of paves the way for us. And so we have an obligation to make sure we're implementing it in the field sort of according to what the evidence says. So Dr. Nick, you already gave us a wonderful example, but you also have experience evaluating programs and all. So is there anything else you'd like to share just to sort of elevate the impact?
Yeah, I think stories are always really impactful. So I can give you a couple other stories of why our navigators and what they do. So I think a population we often forget about is people with disabilities. They have a really challenging time getting through cancer treatment, and a lot more people have disabilities that is visible. There's often hearing loss, visual issues, and I recently treated a few patients with these situations. One gentleman with profound hearing loss and one with visual impairment. And you just realize how much harder it's going to be for them to get through all the steps. So we have navigators who give these patients that extra touch. So for the gentleman who with hearing loss, you have to learn how to communicate with the person differently. You can't just call them on the phone and leave a voicemail. You have to figure out, am I texting them, am I sending them an email, how do I make sure this gentleman's going to make the next appointments that I've set up for him. But they did that, and he's starting treatment. Then there's another patient who I'm actually currently treating with profound visual impairment. So he's going through a whole different set of issues getting through his care. But again, our team, our navigators, are really making sure, okay, so he can't read, right, what you've printed out for him about all his appointments. So how else are you going to communicate? How else do you let the whole rest of the team know that? And how can you be his point person so he has that comfort? I'm not lost here. I know who's going to help me. So I just think there's so many ways that navigators act as that glue. And it's more than just, oh, there's so many appointments, how do I get it for you in a shorter way that makes more sense? It's really, like to the point raised earlier, it's about that person and their humanity and their dignity and helping them get through the treatment and having them really feel seen for who they are and what they feel like with.
Thank you for sharing that story. I think it raises a really great point around sort of inequities. We talk a lot appropriately about racial inequities, but there are other populations beyond race that sort of suffer inequities. And so I just really appreciate you highlighting the disabled population, which is sometimes hidden disabilities, even that we're not aware of, that are impacting our cancer patients' ability to get the best care. So Christine, you come at this with a little bit of a different lens. I wonder if you want to spend a little time talking about the successes of the roundtable and how they really helped us move this field forward.
I thought you'd never ask. So first let me talk for a couple of minutes about what the roundtable is. Today we are sitting in this amazing space and we are all representing different organizations, healthcare organizations, business, academia, etc., community-based organizations. And the American Cancer Society and ACS CAN are masters at convening. We are masters at bringing together diverse groups to join forces to address issues that are bigger than one organization can address. And the ACS discovered this about 25, 30 years ago, and they started to create roundtables. And they created a lot of roundtables. There's one on colorectal cancer, there's one on breast, there's one on lung, there's one on prostate, there's one on cervical, HPV, and the National Navigation Roundtable. So we've been the ACS National Navigation Roundtable, or NNRT. You will hear me refer to us that way affectionately. It's been around since 2017. Dr. Tracy Battaglio was the founding chairperson of the roundtable. And they came together to really say, we know patient navigation works. How are we going to sustain this? How are we going to take all those individual stories that I've heard so eloquently spoken today and make them so that we can make sure that healthcare systems that are providing care see this as essential part of the workflow in terms of getting patients to access quality care, to be diagnosed in a timely manner, to go through treatment and have treatment adherence, to go into survivorship, and or if survivorship is not in the cards for them and it's end-of-life care, that they can have quality end-of-life care as well and be navigating through that. So the roundtable has come together. They have a 5-year aim. I thought it was so great that Mr. Rapper talked about, let's do it, let's put some plan for 5 years. We're about halfway through that 5 years. And what we've been talking about is how do we make navigation sustainable, and what does that include? And so the roundtable has worked very aggressively with my colleagues in CAN. I think sometimes they're mad at me because I'm always knocking at the door saying, this is really important. We need to make this difference. We have reviewed how are we going to fiscally pay for this? How are we going to have a revenue stream, right? How are we going to connect that there are standards of care that Tracy's identified? Because navigators they're nice people. They're all nice people. I like to think that most of us are nice people. But they have a really important skill set. And that skill set helps to be able to get patients from point A to point B, wherever that point is. And you've heard about some of that already today. Can I meet the patient where they are? Can I assess what is the things that are impacting the barriers to care to them? Can I connect with their natural resources that exist? These take skills that we all need to learn. So the roundtable has done a lot of work around educating healthcare providers, and we really focus on policy-related issues. Our membership is almost 150 organizations. The organizations are the members, and we invite people to represent those organizations who have the ability to impact policy. Policy in their system, policy at the community level, the state level, the federal level, to really help to push navigation to be in the forefront, and for there to be reimbursement, that people understand what the standards are and are following those standards, and that they're integrated into the health systems where delivery is happening, so it's functional. So the goals of the navigation program are also aligned with the goals of the organization. Because what we also know is that when navigators are there, not only is it positive for the patients, guess what? For the providers, they are more satisfied. And for the patients, there is also increased patient satisfaction. I see my colleagues here nodding, right? So I'm hitting the nail on the head with that. So the roundtable is committed to educating, to advocating, to bringing the voices together, to commenting at times. So I'm going to guess most of the people in the room know about the fact that the Centers for Medicare and Medicaid, for the first time in 2024, began to reimburse for patient navigation for patients who are in treatment, right?
That's something to talk about.
Yes, absolutely. And I'm going to be the first to tell you, it is not perfect, but you don't throw out the baby with the bathwater, right? We have to really take this as a step moving forward. So in short, the roundtable is very committed to convening like-minded people to really push navigation forward and to really look at the big policy issues, whether it's the advocacy issues like Ken is addressing, or if it is policy issues that need to be happening in respective community-based organizations and healthcare systems. And we're also very invested in building the workforce. So we know that the workforce needs to understand the standards of practice, be trained in it, and then for that workforce to be able to grow. Because the more complex healthcare gets, the more navigation is needed. Am I being a little too passionate
No,
here?
you're great. Spot on, spot on. Molly, how are we doing on time? I'm good. 20 minutes, okay. So we've been hearing a lot of really great things, right? And so it's not all cookies and cream, right? This is not easy work. It's really complicated, hard work. So I want to spend a little time talking about the obstacles to doing this work and what our experienced panel has experienced in their own day-to-day work about what are the obstacles and barriers to doing evidence-based navigation for all patients who need it. So since we're going in order, I'm going to keep us going in that order. So Jennifer, if you wouldn't mind sharing, what are the biggest challenges you have as a nurse navigator manager?
I think educating my physicians on how important this is. No, right. Not that I take the time to have to make them understand, because they do understand and they do appreciate what we do. But the crunch time that it takes from the moment of diagnosis or the suspicion of the cancer to getting into that appointment, there's a lot of relationships that you start to build with your physicians. You all of a sudden become very familiar with personal cell phone numbers, asking for favors, reaching out at all hours of the night via email. I spoke to your secretary and she gave me an appointment 2.5 weeks out, and I appreciate it, but I need to get such and such in by the end of the week. She's very nervous, she's very anxious, and I really want her to see you, and you know what? You're a perfect fit for her. And that also becomes a very big piece of navigation, is understanding your patient's personalities and fitting them with the correct physician. Because yes, can any of us knock on a door of any doctor and say, hey, I'm going to see you because my aunt recommended you? Sure. And he's going to see them, and he's going to diagnose, and he's going to make a plan for them, and that's great, and they're going to come back to me and be like, I'm still not happy. We find somebody that I connect with. Because that connection is what we aim for. The beauty of Northwell is our vastness and the opportunities that I have so many physicians at my fingertips. And I get off the phone with certain patients and I'm like, that one's not going to work for this one. That I really want, even though he's around the corner from his house. And it's a 5-minute ride and he can run there during lunchtime because it's just not going to click. And that click is everything. So then reaching out to that physician, explaining my side of the story, waiting to hear back from them, constantly calling them, emailing them, begging them, waiting for orders to be put in, just getting the word out of the importance of what I'm actually trying to do. And again, there's not resistance, but it just takes time on the education piece.
I think it's a really great point, sort of provider sort of understanding of the appropriate roles of navigation and sort of what the boundaries are for what navigation does is really, really, really critical. But I think your description just now sort of highlights what I think navigation is really patient-centered. It's what the patient needs. And as a practicing physician, like we don't always know as providers what the patient needs. We think we know, but I think the navigators have a better sort of sense of what the patient needs, and so we need to come along. So thank you for that.
Sure, yes. So first of all, it sounds like your physicians are kind of ungrateful. So welcome to come to I think this is going to be recruiting. No, but I mean, and I agree, I think that does highlight a very patient-centered thing. I mean, and just to share personally, I mean, it's about my mother-in-law, so I think that's okay. But she had breast cancer and she's a widow, and she said the navigator was the most important person in her entire cancer journey. So I think that highlights that. But in terms of challenges, particularly at our institution, we've been able to expand a lot of our navigation for screening. And the reality is we live in a healthcare environment that's driven by economics, and that's just the nature of the U.S. medical healthcare system. And so it's easy to convince people to say, we're going to screen more patients, which means we're going to have more patients, and they're going to want to stay with our system. Yes, we can show some success with stage shift. We detect more early stage lung cancers, for example, and we have a very robust lung cancer screening program, and that's what we've shown. But, the challenge that we struggle with a little bit is getting people to buy into the idea that you also need to pay for navigators once people are diagnosed with cancer to get them started with the treatment on time and through the treatment and even in the survivorship realm. Because that's not a tangible thing. And so this is where, reimbursement helps with sustaining programs, is because it's easy to point to graphs, but here you can actually say, no, this is also a program that will pay for itself. And it benefits everyone in the long run, but it's really building that system and sustaining it. Unfortunately, it's going to have to require some economic buy-in, and then particularly in populations where you have a lot of public insurance and these kinds of things, because they're the people that need it the most, right? I mean, we can all agree on that, I think. So that's where I think we struggle in building our program.
Maybe you think of navigation as another innovation in care delivery, like a new screening test, new diagnostic. We only giving it to the people who are already doing well. We're not going to actually make an impact on our inequity. So thank you for highlighting that. I want to stay with two of you for a second because I think I'm curious, and I think the audience should understand, how are you currently paying for your navigation programs? Because it sounds like, and correct me if I'm wrong, Jennifer, your program is kind of embedded into your system. It's part of the operating sort of structure of the system and not necessarily the case in your system. And so maybe you could just talk briefly about funding.
Funding is a challenge we all have every single day. Anderson, my director, and my CNO are here in the audience with me today. And it's a constant conversation. You mentioned earlier about Medicaid patients and finding reimbursement for that. Grant money is fantastic, and thank God for it. There are wonderful people in this world with philanthropy and offering grants. The thing with grant money is we get it really fast and we use it really quick. And thank God we do, and it's a beautiful thing, but it's sustaining the availability of it constantly and reaching out for help and asking people to offer accessorize something so simple as transportation, and then being able to reach everybody. It's definitely a challenge. Proving our worth every day is something that we do. Even when it comes to needing more navigators, I'll say, we need more, we need more, we need more. That's great. Give me a reason why. Show me why. Evaluation and data. Yeah. Constantly.
Yeah, I mean, so I think we, like I said, we've been able to pay for the screening side of it pretty robustly, and our health system has bought into that. It's the other side of it where we've had to rely on grant funding and these kinds of things. And what we've done is try to be strategic about it, sort of getting into that, as we were talking about earlier, equality versus equity. We also, as one of our grants that we have, is for community health workers, specifically for oncology. And so what we do is we do a fairly robust social determinants of health screen for all our patients who come into our oncology space. So it's just a 10-item questionnaire asking them, do you have challenges in this, that, and the other? And if they say yes to any of them, they meet with a community health worker right away. Which, again, then it makes that patient stay with your system. But, the challenge is convincing your hospital to say, this is important for us, not just in terms of patient outcome and patient access, but this is important for us as a hospital system, but getting that buy-in. Yes, the business case is unfortunately part of what you have to do.
I just want to highlight your use of the social determinant screening is a beautiful example of equitable care, right? So ensuring those who need it are identified, and the resources are allotted to serve that particular population. So thank you for sharing. So Dr. Techney, any obstacles or barriers in your work in doing navigation, whether it be due to sort of reimbursement or payment or otherwise?
Thanks. So I want to build off of what everyone else has said, but not rehash it. I want to, there's a kind of famous saying, what gets measured gets managed. So if we're measuring something, we manage it. Now, why does that come into play here? So our insurers are often managed or measured on how well they do with screening. So screening is something that's measured and therefore gets managed and cared about. What we don't measure as well, because it's harder to measure, is what happens from when something's identified to starting treatment, how well do people do adhering to their treatment, and then survivorship. Those aren't measured as well. So we don't manage them as well, but we have to take the initiative and be leaders and say, this is important, here's why. So what we do internally, we advocate for our cancer patients and our cancer programs. So we created business plans that have their staffing models that we need a patient navigator in each clinic, and that gets passed, so that becomes the model, and we follow that. And I think that, to add on to the social determinants of health, we do that in all of our primary care clinics, and we have community health workers who do shared decision-making with the patients to talk about what goal are you working towards. So this is not in the cancer world, but it's in the general sphere. So that's really important. And then I think in terms of other barriers, obviously the economics, the reimbursement. If something's paid for, you do more of it. That's the incentives that currently exist in our healthcare environment. So we should be paying for things that do well for the patients, right? Like if this is going to affect patient care in a positive way, we should be paying for it. Sometimes our incentives are misaligned in healthcare, and that's a whole other panel, right? We could talk about that for like another 2 hours. But I think that the work that started with the American Cancer Society, and thank you to the Cancer Action Network, this is so important, and we're looking forward to the great things to come.
Just put a plug in for the American Cancer Society Lion business case toolkit that they've created to support health systems who are trying to sort of create the business case. And we need to make you a case in that toolkit. Christina, do you want to talk about, I mean, you can talk about anything you want related to obstacles, but I wonder if you want to talk about the pulse survey?
Can I talk about some of the solutions too, or some of the opportunities to help to create solutions? So, so first, I want to say that we are definitely seeing across the country that even though that we know there's reimbursement right now, the Roundtable recently did a survey. We spread it far and wide across the country. Only got 200 responses. And if you think about how many healthcare systems there are in New York State alone, you know that that was a huge number. But only about 10 of those 200 organizations are using the reimbursement tools that are available through CMS or through private insurers. So one of the things that I want to encourage all of you to do is to become educated about what is available in terms of reimbursement. And one of the ways to do that is to sign up for the emails and programs that the Roundtable are doing. You can email us at how do I do it? nnrt@cancer.org. I forgot how to do an email address there for a second. You can email us and ask to be put on our mailing list, and or you can visit us at our website, navigationroundtable.org. You can also find that if you can't remember, because I know some of you aren't necessarily going to be taking notes right now, you can go to cancer.org and look up patient navigation, and it will connect you to the National Navigation Roundtable. We will be doing a webinar in December 11th, in fact, where we're going to talk about the business toolkit that ACS has developed, and how do you connect that, and give you a couple of case examples from people in the field who are actually offering it. We know, as I mentioned before, that it's not a perfect world, and work that CAN did in collaboration with NNRT was a landscape study to look at how are we going to pay for navigation. And what they found is it's not going to be one size fits all. It's not like, you know, you're just going to pay. So, or we're just going to bill insurance. So part of what we need to do is we need to look at a state level, a federal level, and unfortunately we need to continue to look to private funding. And the bad news is it's only been private funding, as Jennifer said, in the past. And when the money's run out, and I know this firsthand from my work at ACS, and I met one of my former navigators here today, Sheila, great to see you. It's the money runs out. You can't continue to pay for the navigators. So we're going to need to kind of put something together, a beautiful quilt of how we're going to reimburse. And one of the things that CAN's going to be working on in New York, and I'm so excited about this, is trying to get Medicaid to pay for patient navigation, because right now it's not covered. And we know that this is the population that needs navigation the most. This is the population that could benefit the most, that we could get diagnosed, we could get screened earlier, we could get diagnosed earlier, and that they can have better outcomes. So this is going to be an opportunity for you. We need to continue to hear those stories, because that's what lawmakers want to be able to hear. That's what gets at their heartstrings. We need you to be CAN members. We need you to learn about what's going on around navigation. The other thing that CAN's going to be doing is that they're going to be lobbying the state legislator here and the governor to get funding to be designated to go to the New York State Department of Health, so that the New York State Department of Health will then create a request for proposals and be able to have some grants that will support navigation. Your voice is going to be needed to be heard in that. So being a member of CAN here and supporting the work that's being done is going to be really crucial. So I'm just going to say in short, I know the world isn't perfect, and it's not perfect around reimbursement, around getting our organizations to support it, but please continue to be aligned and learn about the roundtable. I'm going to hang out after. If you have questions, find me. I'll be happy to chat with you about it and get involved and learn more about what's going on and stay educated.
Thank you, Christina. Wonderful talk. I kind of want to move to New York now. There's a lot of good stuff happening here. So we have just a few minutes left in our panel. We could stay up here all day, and I see there's an audience member who's raising their hand, so maybe we'll end with a question. Is that what, please?
The question was, is there an AI solution specifically that can be used in more underserved communities to kind of help, versus potentially some other areas where there is more resources available human-wise. So, interestingly enough, we're working with a company that piloted some programs with an AI that calls people for screening. So people that miss colorectal screening or lung cancer screenings, it will reach out to them, remind them that they, qualified for this screening, that they need to come to this appointment, and the person can then interact with it. This is similar to like a chatbot you get when you call a company, but it's trained specifically on healthcare, and so it will actually do exactly what you're asking for. Now, that being said, we all get calls from those, and I would say a lot of people hang up. so the challenge is getting people to interact with it. But we have shown some really good engagement with that, and it's a wonderful tool that we're trying to leverage for that purpose.
It's not surprising we have an innovator on the stage today, so that's great work. I'll also share that the President's Cancer Panel this year, their topic of the work group from the President's Cancer Panel was leveraging AI to advance navigation, and they're going to be publishing a report to the President by the end of the year, suggesting some steps towards that. So I think we're going to see much more of that. We could stay up here all day. I could stay up here all day. I think we have just a few more minutes. I want to give our panel, first say thank you to everyone who's here, for your attention, for your questions, to this esteemed panel who I've learned so much from, for the work that you do every day. Continue to inspire me in this hard work, so thank you for that. But I want to give each of you an opportunity, just any final words that you would like to share about your own experience, about what you want the audience to know, or anything.
Don't stop. We all need to keep going. Just quickly, unfortunately, my father had just passed this August from lung cancer. And he wasn't a patient of Northwell. He was a patient with another very esteemed healthcare institution with no navigation. And what an eye-opener that was for me on a personal level as his daughter and also as a nurse. I truly learned firsthand the importance of navigation, because you know what? At that time, I didn't want to be the nurse navigator. I didn't want to be that role. It's a very different place, obviously, when you're on the receiving end as a family member. And when he finally passed, my mother turned around to me and she said, if it wasn't for you, what would you do? And I took that very seriously, and I've had many conversations with my team leaders, and I said, this is why we need to keep going. This is why we need to give the daughters and the sons and the family members the opportunity to be with their families and not have to worry about this. And it truly did hit home, and it just solidified every day why I do what I do passionately and keep on doing to get to where every patient needs to be, every family member needs to be. So I'm forever grateful for my position and my role, my leadership that is outstanding with the support and understanding. And a lot of our navigators have gone through cancer themselves. So it does come directly from their mouth. And it's something that's organic that can't be taught. So it's a little bit of me. Thank you.
So I would just say that I agree that we really need to move this forward. It's not just about the numbers and the graphs and how we improve survival and how we move from early stage, stage shift into early stage diagnosis. A lot of this is about bringing the humanity back into cancer care. It's such a vulnerable position for patients to be in, and not only from the perspective of the patient, but also the perspective of the people who are delivering the treatment. Having someone who is looking out for that patient is really crucial, and you see the benefit of that it's not falling on your shoulders or your team's shoulders. We're just focused on the treatment part. To have someone who is thinking of all the other things that are going to matter, that are going to fix some of that soil, right? You have to do your gardening, and so bringing that humanity is really important, and I think it's so crucial and helpful. So thank you, and please, yes, please keep advocating, fighting, helping us make this happen.
Dr. Tucky?
Thank you. So I want to get back to the question that was asked about the AI part, because I want to really focus on this concept that it's not, AI itself is a wonderful tool, but it's not a solution. Right? AI is going to help us do our work better. There's a great quote that's, artificial intelligence will not replace physicians, but physicians who use AI will replace those who don't. And that's because it's going to help us do the things we do better. Things like identifying patients who need to be screened. AI is great at that, right? It can look through the charts, this hasn't been done, this should be done. But then who needs to call a patient? Who needs to schedule? Who needs to have that shared decision-making that our navigators do? That's still a personal touch, and that's what we call EI, right? Emotional intelligence. How do you connect with the patient as a person? So I think it's going to be both. It's going to be technology and humanity, but this is still a patient, a person-centered field. Medicine is about people. And I love technology. I give talks on AI. We use it in our day-to-day practice. I wish it could be as easy as we just implement AI. It solves all our problems. But that's not how it's going to be, right? It's still all about the people and the human touch, because it requires coordinating what people are going through. So I just want to leave us with that thought, that patient navigation is not going to go away. It's still going to require people. Their work may be enabled by technology and AI, and I hope it will be, but we still will need people, and I think we're actually going to need more people because the care is getting more complex. There are more diagnostics, there are more treatments. So, something to think about as we look to the future. AI is not going to solve it all. Hopefully it'll help our work be a little easier, but we still need the people.
Great points, thank you for that. Christine, take us home.
I want to just say thank you for having me here today, for everyone sharing their stories. And I know that there's many more stories in the audience. And I really, again, want to encourage you to share your story with the American Cancer Society and with ACS CAN, because that's one of the ways that we're going to continue to push this forward. So, and I know that, again, this is, I'm preaching to the choir. You're here because you believe in this, because you, as has been said since our opening remarks, we've all been touched by cancer in some capacity, and we know that this personal touch is really incredibly important. So thank you.
Thank you. Thank you, everyone.
How about another round of applause for our incredible panel? Dr. Battaglia, Mr. Barrow, Dr. Menko, Dr. Teki, and Ms. Thompson. Your insights today are invaluable for those I haven't yet to have the pleasure to meet. My name is Annette Spellin, and I am the Vice Lead Ambassador for ACS CAN in New York. I am a retired detective of the New York City Police Department and a survivor of lung cancer, which I developed as a result of working at Ground Zero. Fighting cancer is imperative and a personal commitment. I want to thank you all for joining me in this fight and attending today's policy forum. As you heard today, patient navigation is revolutionizing how we treat cancer, utilizing a community-based approach to do so. It was in this very community, in the community where I was born, that patient navigation was also born. It feels kismet that we're discussing its importance just blocks away from where it was founded at Harlem Hospital, in response to one doctor by the name of Harold F. Freeman, who noticed that women, many of them black, were repeatedly coming to the hospital too late to be saved from breast cancer, despite living within walking distance of the hospital. Through Dr. Freeman's work, we were able to discover that patient navigation greatly improves patient access to care and health outcomes by eliminating barriers across the cancer continuum, particularly in under-resourced communities. He knew, as many of you do, that cancer is hard, but supporting patients through navigation is ensured that their needs do not slip through the cracks, can make it easier. Unfortunately, as you heard, the impact of this innovation has been limited by insufficient coverage, meaning that patients, namely those who are under and uninsured, are coming up against roadblocks in their pursuit of patient navigators. I believe, as my fellow advocates do, that everyone needs access to affordable quality health care. It is critical to ending cancer as we know it for everyone. It now gives me a great pleasure to introduce someone very special. Please welcome to the stage our final speaker, my fellow volunteer and friend, Grace Sherry.
Well. Thank you so much for having me. I'm really blessed to be here. Today's what? Today's Thankful Thursday, right? So we're thankful to be here. Look up to your neighbor and say, I am thankful to be here. Thank you so much. You know, we're all connected one way or the other by cancer, whether remotely or directly. And so I am so privileged to be here, to stand in front of you all and tell my story as to how the very important theme, which is patient navigation, influenced my healing and recovery. So before I go on, I'd like to introduce myself. My name is Grace Charrier. Aside the work that I do in the cancer community, I'm also an author, a peer reviewer for the Breast Cancer Research Program at the Ministry of Defense. I'm a talk show host, an avid traveler, I'm a foodie. All these were made possible by my survivorship. And my survivorship is actually attested to my experience with patient navigation. So, let me tell you what happened to me. My story goes like this. Picture this, it's 2016. A seemingly healthy and happy me. I was running the bath in the bathroom, in the shower, and the next thing I knew, I lost consciousness. I was startled. I reached out to my PCP, and I was asked to come in and requested to have series of tests, to determine why that fall happened. I had to go through the, usual series of tests, which included an echocardiogram, a colonoscopy, a PET scan, an MRI, two minimally invasive biopsies, which came after a mammogram. It was after all these that I got the shock of my life when I had to face the oncologist who told me that I had stage 3 triple negative breast cancer. Now, you can imagine the shock. I had no symptoms, I had no itching, I had no pain, nothing. I was like a walking time bomb waiting to explode. So this started a series of steps, and of course we all had to go down that rabbit hole. Now, my blood pressure apparently was one of the causes because it was seen to have hit the roof almost 170 over 110. And so my PCP had to request that, we looked into that. And after all these happened, that was when this conclusion, was brought about, that I had breast cancer. So as you can imagine, at this point of my ordeal, I was confused. I didn't expect to, hear this kind of, shocking, traumatizing result. I was like, okay, how can this be? What is going to happen? What tests? Do I even have insurance to cover this? Where are the interventions going to take place? Where am I going to have them done? How am I going to get there from, like, our wonderful healthcare professionals here preceded me? And so her name is Minnie, and she is like, the unseen angel, let us put it that way, that was with me every step of the way. Now, I want to raise this issue that I had already been turned away by several oncologists who refused to take my health insurance. And I was completely mortified because I was like, okay, I'm having this, who knows, stage 3, there's just another stage to get to stage 4, and God forbid, palliative. How could they turn me back, And so it was she, Minnie, that said, relax, everything is okay. We're going to see how we can get you through this. Just take time. You only have to think about how you're going to get well. I'll take care of the rest. And so she was the one that found that oncologist that was one of those that saved my life today. I wish he could have been here. He's in India at the moment, Dr. Killen, who was actually a part of those moving parts in my multidisciplinary care team that helped to make this possible. Minnie was like the link, to everything that happened to me. She saw me like, the panel had mentioned, meeting the patient where they are. And I wasn't a statistic to her. I was a human being. She saw me when I was sad. She saw me when my energy was being depleted. She saw me when I was going into a state of depression. She saw me when I was complaining about how my resources were dwindling financially. She was with me every step of the way. And I can't cease to continue to, show my gratitude to her 8 years later, because I think that without her, a lot of the stuff, those gaps, they talk about closing the care gap. She was one, and that glue that the good doctor was talking about, she was the one that actually cemented that gap for me. So she was my ally and helped to celebrate me every step of the way when I was beginning to make that, recovery process. it made me feel empowered and all that. So what more could I have wished for at that point in time when I needed hope? Because when I started, I didn't have any hope. I didn't know how I was going to get through. But she was the one that really helped me go through this. Now, patient navigation is actually the very core. We're talking about, like the panel said, patientricity, as they say, patient-centric. That's what it is, because actually, without patients, there wouldn't be any navigation, right? So this is the whole essence of the importance of this very core and critical tool that is underutilized, that is not even known. I mean, without a friend of mine bringing up the topic of a patient navigator, I wouldn't even have known that it existed. You know, she was the one that said, listen, you're paid over to treatment every week for chemo, for radiation. No way, you know, let's get you a car service that will make sure that they come pick you. You just have to, you know, get in touch with them and let them know that, okay, on Monday, from this time to this time, I would love you to come pick me. You know, they'll schedule you and, you know, make everything seamless. And that was what happened. Prior to that, without her telling me about transportation, being a part of the, you know, solution as we're talking about and helping to make life better for me, I wouldn't have known. I was paying over like about $70 on each trip. So you can imagine how much had accumulated over that length of time before I now had, you know, free transportation to take me to and from my chemotherapy, radiation, and even after surgery, you know. So unfortunately, too many of us as patients and caregivers, you know, because we forget a lot about the caregivers. Our caregivers bear the brunt. You know, when we go in to see the doctor or, you know, the oncologist or whatever, most times I'm like, you know, I don't even know what's going on. Usually it's my daughter that takes her phone and records and says, listen, you listen to this, you know, when you get home, because you're too immersed in what's happening to you, you know. And this is something that, you know, a lot of the patients do not know exists. It's not you know, talked about often enough. And I'm so happy that this has been brought to the fore. Because many of us are either underinsured, not insured, cannot even, you know, be up there on the radar asking for reimbursement or whatever. No. So many of us would just, you know, go with the flow, maybe deal with the expenses out of pocket, and that leads to a lot of financial toxicity, because I know that even though I earn some good deal of money, you know, but it really hit me, you know, it hit home by the time I would see how much, you know, I was left with at the end of the day, you know, because a lot of things had to change. I couldn't eat all the food I was used to, and I had to, you know, become, you know, change my diet. You know how expensive organic meals are. You know how much it costs, you know, to buy food and all that. So we at ACS Camp, we are imploring you to work with us, to hold our hands as we see that New Yorkers and even beyond know much about this very critical tool, patient navigation, and try to enlighten, you know, communities so that communities can be empowered. By the time I was involved with my patient navigator, she empowered me. I mean, yes, I was doing a lot of self-advocacy and all that, but at the same time, she was like, you know, the fire under that was saying, you go, girl, you know, you've got this. And if you continue this way, you know, you'll be able to heal well and recover well. So we need to start asking questions and also keep the momentum going, just as we're doing here, you know, to try and, you know, have that round table, like the lovely lady said, to really heighten awareness about patient navigation and see that everybody's on the same page, as regards that. So, ladies and gentlemen, before I leave you, I'd like to ask this simple question. To say, would you like to hold our hands and come with us as we raise this very important subject and theme, patient navigation, because really, this is something that is really critical to our well-being as patients, as our caregivers as well, and survivors like me. Touch wood, where's the wood? That I don't have a recurrence, but it's always at the back of my head that a recurrence will occur, and if it does, what do? I would still go through that process of having a patient navigator walk with me all the step of the way. So, before I end, I would like to say once again that patient navigation gave me clarity, gave me guidance, empowered me. And that is what, led me to start my talk show, to be able to put across that information that I really didn't have, and then make sure that other people would get to know about it. So please walk with us at the American Cancer Society Cancer Action Network as we, empower New Yorkers, and other states hopefully will follow us in this regard. To see that patient navigation is something that we can really hold on to be able to improve outcomes for anyone that is facing cancer. So I would like to finally leave you with something that Dr. Tedros, the World Health Organization Director General, said at a recent gathering I was privileged to attend. And he said, and yet, for every cancer survivor, there are some who are not here to tell their stories. Thank you very much, and God bless you. Now, I would like to hand you back to Annette Spellin, my dear friend and fellow cancer advocate, to round us up. Thank you so much.
Grace, my friend, I want to thank you so much for sharing this story with us today. It encapsulates so well, and we advocate as we do to ensure that the patient experience is front and center as we develop our policy and endeavor to improve access to care. We at ACS CAN are eager to pull together the voices and perspectives in this room to ensure that patient navigation becomes the standard of care. There is no doubt that when we come together as a chorus, our voices are stronger and our goals more easily achieved. If you are interested in lending your voice to this campaign or want to learn more about our work to improve access to paid family and medical leave, increase funding for cancer screening, and build on the progress of tobacco prevention, please connect with one of the volunteers of our staff or one of our volunteers in the room that have ACS CAN listed on their name tag, or visit the ACS CAN table where you check in this morning. On behalf of the ACS CAN staff and volunteers, I extend our deepest thanks to all the speakers and supporters and your commitment to work with us to help save more lives from cancer. This concludes our program today. Thank you so much.